The question has recently been brought up, well, now that we have new ways to treat systemic therapy, using tyrosine kinase inhibitors, for example, does that old paradigm still apply? Does it matter? And so there was a clinical trial called Carmina that tested the notion whether a cytoreductive nephrectomy added value when it was added to systemic therapy using a tyrosine kinase inhibitor, in this case sunitinib. And the bottom line is that Carmina showed there really wasn't a difference, which frankly was a shock and a surprise to most of us. Most of us assumed there would be some difference, and it turns out really there wasn't. And so the issue now is, how do we now integrate the findings from that trial into our old paradigms, and how do we readjust the way we think about the role for cytoreductive nephrectomy in this space? And the bottom line message essentially is that it's still going to boil down to patient selection. So what Carmina tells us is there isn't quite as much of an advantage to surgery as there was before. So you need to be particularly selective about who you choose to do a cytoreductive nephrectomy in. So we should not be using it willy-nilly. We shouldn't be using it in the highest risk of the highest risk people. We should not use it in people who have rapidly progressive disease. Don't use it in people who don't have resectable disease, and essentially don't push the envelope. We used to push the envelope on purpose because we thought we were adding survival value. Now that's not as clear, so there is no point pushing it the way we used to.